Good evening, everyone. My name is Andrea Reiner, and I'm a fifth-year general surgery resident at the University of Florida in Gainesville. On behalf of the Florida chapter of the American College of Surgeons Resident and Associate Society, I'd like to welcome you to tonight's event on fertility and family planning during surgical training. Next slide, please. Before we begin, I would like to just go over a few housekeeping items. Please note that this event tonight is being recorded and will be posted on the Florida chapter website for you to access in the future. If you're not already a member of the Florida chapter, I would encourage you to join, as this organization gives you access to excellent resources, an incredible network of surgeons throughout the state of Florida, as well as leadership and educational opportunities. In addition, we are excited that our annual meeting will be held in person again this year from May 13th through the 15th in Orlando. The agenda for the meeting includes many events for residents and medical students, including Surgical Jeopardy and Olympics competitions, as well as the opportunity to practice mock oral exams. There will also be a resident paper competition and spectacularly challenging case competition. These events have historically included cash prizes, so you should definitely check out these opportunities. Next slide, please. We are excited to have two special guests join us this evening to provide expert insight into family planning and fertility, the latest data on fertility among surgeons, and even share personal stories. Hopefully you will leave this event feeling empowered, realizing ways in which you can be prepared for the future while still pursuing your professional goals as a surgeon. Tonight, we are pleased to have Dr. Amelia Schaub here with us. Dr. Schaub is a reproductive endocrinology and infertility fellow at Cedars-Sinai by way of the University of Florida, where she completed her training in obstetrics and gynecology. Dr. Schaub serves as our content expert this evening, and she will be sharing information on the physiology of pregnancy, fertility, and options for fertility preservation. We are also joined by Dr. Mecker Möller, an associate professor of surgery at the University of Miami Miller School of Medicine. Dr. Möller is a surgical oncologist who also serves as the Breast Surgical Oncology Fellowship Associate Program Director and is the leader of the HIPEC program at University of Miami. She is an active member of the Association of Women Surgeons and has personal and professional interests in advocating for fertility education and access to services for trainees. Dr. Möller will be sharing fertility data specific to surgeons, as well as her own experience with infertility and what she wishes she knew earlier. Tonight's agenda will include brief presentations by Dr. Schaub and Möller, followed by approximately 20 to 30 minutes reserved for a question and answer session. I will also share with you that this topic is near and dear to me personally, as I have firsthand experience with egg preservation, which I actually pursued as a busy clinical resident. So we hope that tonight's events will be informative, empowering, and that we will be able to create an open forum to answer any questions that you may have. You are welcome to post your questions in the chat box, or you may use the hand raise feature during the Q&A session. So without further ado, Dr. Schaub.
Great. Hi guys, I'm Amelia Schaub. As Andrea said, I'm a second-year fellow in fertility at Cedars-Sinai. I did my medical school and fellowship at University of Florida, so love Florida and hope to come back there. And yeah, I'm excited to talk to you guys. This is really important to me. I've really taken an interest in fertility and family planning in medicine, and I think surgery, the field of surgery, is really, for lack of a better words, hit the hardest when it comes to this. So I'm excited to talk to you guys. Okay, so I just wanted to start off by talking about the physiologic decline in female fertility. So on the left here, we have a chart that shows fecundity and its historical data in couples that were not using contraception. So we all know that female fertility declines over time. The most eggs we ever have, unfortunately, is when we're a fetus. We're born with about 1 to 2 million eggs. By the time we go through puberty, we have about 300,000. So even when we're not ovulating, we are constantly losing eggs. It is a constant decline in oocyte quality and quantity. So on the left is just kind of a depiction of that. This shows couples that were not using contraception, and you can see the decreasing rate of fecundity, especially which starts in the 30s. I think, we learn in medical school, advanced maternal age is 35 years old. And a lot of people cling to that and think 35 is when fertility starts to decline. But really 35 is when you start to lose oocyte quality more so as opposed to oocyte quality. So you can kind of see there's a drop off here starting right in the early 30s. So really the truth is oocyte quality starts to significantly decline around 32 and then more rapidly decline around 35. And honestly, I did not know that when I was probably until maybe my 4th year of residency, when I really, knew I was going into infertility and started looking at a lot more papers. I had always thought kind of this AMA 35 years old. So I think it's really important to just know that because it is earlier than people think. So on the right is a chart that shows increasing rate of miscarriage as women age. So you can see it's pretty steady in the early 20s, early 30s, and then really starts to exponentially increase after 35. So this is where that AMA comes from because the rates of aneuploidy start to significantly increase after 35, and that's a reflection of decreasing egg quality. So I really think of the eggs in terms of decreasing quantity and decreasing quality as two separate issues, obviously associated, but they are separate. And so just kind of keeping those numbers in mind, 32 and 35. So some special considerations for women in medicine. The CDC most recent data says that the average woman in the US at the age of their first child being born is 26 years old. For women in medicine, data has shown us that that's around 31 years old. And then for women in surgery, recent data has shown that that's about 33 years old. So, thinking of those charts in the previous slide, you can obviously see that this is going to be an issue for women in medicine and especially for women in surgery. I'm sure you guys have seen this article, and I just wanted to mention it briefly. Dr. Möller is going to cover this article in a little bit more detail. So I just wanted to touch on a couple topics, but this was a survey of surgeons with children, female surgeons, that was published in JAMA of July of this year. So it's pretty recent, but the data from it was really striking. They didn't specifically ask about infertility diagnosis, but of the surgeons that they included, basically 25% of the women who had children had to utilize ART or assisted reproductive technology. So essentially had to see a fertility doctor, had to have some types of procedures, IUIs or IVF to conceive. So just to compare that to the general population, we know that for the general population, 2% of all babies born in the US utilize ART. So, obviously this is really significantly higher, and a lot of female surgeons are going to have to use ART to conceive. The article it's great. If you haven't read it, definitely go read it. And Dr. Möller will touch on this a little bit more, but it did show some other complications for female surgeons as well, including higher rates of miscarriage, higher rates of pregnancy complications, and specifically higher rates of preeclampsia and cesarean delivery. So it was a great article. Definitely recommend reading it if you haven't seen it. And as I said, Dr. Möller will get into the data a little bit more. So what can you do about this conundrum that you're in because of medical training? We're all in because of medical training. So fertility preservation, there's really two options for fertility preservation. There's egg freezing and embryo freezing. So here's a mature oocyte on the left here, and here's a blastocyst embryo on the right. I know it's probably been a while since anyone has looked at embryology. You really have no reason to. So I'm just going to kind of briefly review the very earliest stages of embryology. But essentially, an oocyte has to go through a maturation process during follicular growth and then during ovulation, and only mature oocytes can be fertilized. And obviously, after fertilization, an oocyte cannot go back to being an unfertilized oocyte. Once it's been fertilized with sperm, it's locked in. But the stages of early embryo development, I just like this picture to show a little bit, and this is kind of what we do in the lab. So after fertilization, this is the first structure that shows signs of fertilization, successful fertilization, are these two pronuclei. So you have the sperm and the egg DNA, and this shows that the egg has successfully fertilized. So for reference, when we're doing IVF, and we can watch this happen in the lab, we expect about 75% of mature eggs to fertilize. Of those that fertilize, we expect about 75% to continue to grow on to embryos, to further stages of embryos. So after we see the two pronuclei, we start to see cell division. By day 3, we might have about an 8-cell embryo. And then by day 5, it develops into the blastocyst embryo, which is about 100 cells. And so this is the trophectoderm around the outside here that will become the placenta, and the inner cell mass here of the blast is what will actually become the fetus. So if you were interested in freezing eggs or embryos, and I'll talk a little bit more later about sort of pros and cons of both, but the first thing that we typically do is evaluate someone's ovarian reserve. And this gives us an idea of how many eggs we might be able to get during the whole process. Obviously, more eggs are better. Everyone wants to know, how many eggs should I freeze? What's the best number? It's really hard because it's just a different number for everybody. And ideally, to ensure a pregnancy, one live birth pregnancy in the future, you'd like to get somewhere 15 to 20 eggs. And for some people, that does take multiple cycles of stimulation. So that is definitely a thing, is that people will do multiple cycles to bank eggs. But the first thing we start with is just evaluating somebody's ovarian reserve. Kind of how many eggs do we think you have left, and how many do we think we can get from the stimulation process? So there's 3 different methods that we use to do that. The AMH level is a blood test, anti-Müllerian hormone. I'm sure people have heard of this before. Companies like Modern Fertility are offering this commercially, and it's talked about a lot. But essentially, it is just a blood test that we draw. We like to see the higher number is better, represents more eggs. We consider 1.2 to be the cutoff for below that, diminished ovarian reserve, above that, normal. Obviously, as we age, this number gets lower. Antral follicle count is determined by doing an ultrasound at the beginning of the cycle. You can do it at different points in the cycle, but really the best time is at the beginning of the cycle. And what we do is essentially just count the antral follicles that we can see in the ovaries. So what are the antral follicles? Well, there's hundreds of thousands of eggs resting in the ovary, but each cycle your body recruits a cohort of follicles. These are the antral follicles. One of those follicles will continue to grow to be the dominant follicle that will ovulate each month. We typically obviously ovulate 1 egg per month. The other antral follicles that were in that cohort, they die off. So the more antral follicles that your body is recruiting, the higher your ovarian reserve is. So, a woman in her mid 40s or so may only recruit a couple of antral follicles. A woman in her early 20s might recruit 20 antral follicles. The antral follicle count is probably our most important marker of ovarian reserve, because it gives us a really good idea about how many eggs we can actually get with stimulation. We can only grow what's there. We can't grow additional follicles. Based off the antral follicle count, we typically tell people plus or minus 2 follicles is what we think we'll get after going through the process, and how many eggs we can actually freeze. We also check FSH, follicle stimulating hormone, released by the anterior pituitary. The lower your FSH is better. As we approach menopause, FSH starts to increase. We use 10 as a cutoff for what's normal. For reference, a woman approaching menopause might have an FSH of 20, 30, and then increasing from there. So then how do we actually go about growing the eggs, growing the follicles, and then getting them out to freeze for later use? So controlled ovarian hyperstimulation is essentially just the process of growing the follicles for IVF. It's really just giving a combination of gonadotropins, FSH and LH. When we give these in these high doses, we can grow all of the antral follicles that would normally die off, as opposed to just the one dominant follicle that would grow in a normal physiologic cycle. These are self-administered medications, so you're giving yourself these injections every night. I'm always amazed by how well non-medical people do at giving themselves these injections, so it's really very easy. And you're typically giving yourself these injections for a period of about 10 to 12 days. During that time, you're usually coming into the clinic to get blood work and an ultrasound done around every other day. So the reason for that is we want to keep an eye on how the follicles are growing, and we can adjust the doses to try to optimize everything as well. Based off the blood work, we're just checking an estradiol level, and based off the ultrasound and the growth of the follicles. So this is what an ovary looks like during controlled ovarian hyperstimulation. So for example, during a normal cycle, just one follicle like this would typically grow. So with these gonadotropins, we're growing as many as we can. So the ovaries do get really quite enlarged during the process. And usually around like the 4th day of medications or so, our patients will start to feel more full, uncomfortable, have some bloating. People typically do really well. They continue to go to work, but we ask them to not do any intensive exercise and no intercourse, obviously. So you can just see, this is not a physiologic ovary. It's very enlarged. And it usually stays enlarged for I'd say about a week to a week and a half after the retrieval. And we typically ask people to take it easy during that time as well, just meaning like no intensive exercise. But we continue to grow the follicles, and you continue to take gonadotropins until the largest follicles reach about 18 millimeters in diameter. Once we get the largest follicles to 18 millimeters, we give an HCG injection instead of the gonadotropins, and essentially it's just to replicate the LH surge that happens during mid-cycle to trigger ovulation. So HCG and LH have the same alpha subunit, so that's why HCG is much cheaper, that's why we use it. So this different injection is given to cause the final stage of maturation of the eggs. About 36 hours later is when we do the oocyte retrieval. The retrieval it's a pretty minimally invasive process. It's just a transvaginal ultrasound with a 16 gauge needle attached to it. We go in and aspirate the follicles. So the needle goes through the back walls of the vagina, goes directly into the ovaries, because the ovaries being enlarged, they really just kind of fall right behind the uterus right there. So there's not really anything else we have to go through to get to them. And we aspirate each follicle until we basically get all the follicles, and these are going straight to the embryologists in the lab who are directly collecting the oocytes. So complications with it are really rare. Obviously, with any procedure, we say there's risk of infection, risk of bleeding, risk of injury to bowel bladder, extremely rare. I haven't seen it in my 1.5 years so far of fellowship. I know it has happened, but it's generally very safe and a very simple procedure. And then I wanted to circle back. So once we actually have the eggs retrieved and in the lab, what do we do with them from there? Well, if you're just freezing eggs, they're frozen that day. If you're freezing embryos, they're fertilized that day. So really, what's the difference? Well, obviously, if you're freezing embryos, you know what sperm you want to use. I have a lot of patients, and this I think people throw this around, and so it gets a little bit confusing, but people will say, oh, is freezing embryos better than freezing eggs? Obviously, freezing eggs gives you more social flexibility, because then when you want to use them in the future, you can choose whichever sperm you want to fertilize them with. And I don't think freezing embryos is better than freezing eggs. It's just that you have more information about embryos. So with eggs, we can only freeze the mature eggs. I'd say generally about, it kind of depends on the cycle, but generally about 80 to 90% of the eggs we get are mature, because only mature eggs can fertilize successfully. But from there, once we have the eggs, if we are fertilizing them, only about 75% fertilize. And then from there, about 75% of those will continue to grow onto blasts. What's really become the standard of care in the field is to perform genetic testing on blasts, which is we just call it PGT for short, pre-implantation genetic testing. And essentially what we're doing is taking a small biopsy from, this is a hatching blast, so the trophectoderm batches out of the zona pellucida, and we take a few cells from it and send it for next gen sequencing. This has really become standard of care because it lets us see if it's an aneuploid or a euploid embryo. So right now we only implant euploid embryos. We don't do anything with aneuploid embryos, and mosaic embryos are kind of like up in the air right now in the field, but generally not transferred. And that's because we know that aneuploid embryos are not going to lead to a successful pregnancy. They're either not going to implant or they're going to lead to an early first trimester miscarriage. So it's really pretty standard to do this on the embryos so that we know which ones are euploid. A euploid embryo does have about, depends a little bit on maternal age, but anywhere from 60 to 80% chance of becoming a successful live birth pregnancy. So if somebody were freezing embryos, we would grow the embryos out to the blast stage, perform this genetic testing. Let's say, for example, somebody had 5 embryos that were biopsied, and then 3 of them ended up being euploid. That's a pretty good chance of having 2, maybe 3 children in the future. So the only issue with freezing eggs is that we don't know how the eggs are going to perform. So if you freeze eggs, they'll thaw just fine. Our thaw rate is great. It's over 90% now with new technology, but we just don't know how they'll fertilize in the future. We don't know exactly how many euploid embryos somebody will get. So I think, it kind of was a thing to say, oh, freezing embryos is better than freezing eggs, but I really think it's not necessarily true. It's just that you have more information about what an embryo is going to do in the future. We can't say for an egg, like this egg has a 60 to 85% chance of becoming a pregnancy in the future. This is just an example of the blast development again, as we talked about, and PGT. And then I did want to talk about, so if somebody decides, yes, I want to do this, I want to freeze my eggs, or I want to freeze embryos with the partner I'm with right now, or with donor sperm, whatever. And, I want to have kids maybe 5 years down the line. What is it going to look like when you actually go to use those eggs or those embryos? Well, obviously, if you freeze eggs, the first thing that we'll do is thaw the eggs, fertilize them, ideally with fresh sperm. You can use frozen sperm as well. And then we'll grow them out in the lab and watch them become blasts, just like we talked about before. Typically, we do the genetic testing to see which ones are euploid, and then we get ready for a transfer. So I just want to mention, getting ready for a transfer does take a little bit of time and preparation. What that involves is usually taking oral estrase for about 2 weeks to build the lining of the uterus. And once it gets to an appropriate thickness, we give progesterone to compact the lining and cause luteinization to get it ready for the embryo to be put back in. The embryo transfers are really, it's just like a clinic procedure. There's no anesthesia or anything. It's just a really small little catheter with the embryo loaded into it that goes right into the uterus under ultrasound guidance. We place the embryo there and you're done. So, it takes about 10 minutes in the clinic. The egg retrieval too, I'll just mention, it is usually under IV anesthesia. We usually give propofol and Versed because it can be a little bit uncomfortable, as you can imagine, to have a needle go through the back of your vagina. But patients feel really well afterwards. We tell them always not to work that day because they've gotten anesthesia, but most people go back to work the next day. But yes, it's a little bit of work to use the embryos in the future. I just think it's important for people to know, because you don't have a corpus luteum from ovulation, we've instead given medications to build the lining of the uterus. You have to continue to take these medications until about 10 weeks into the pregnancy, when the placenta can then take over and produce the hormones that are necessary to sustain the pregnancy. So what complications and risks are associated with this? I think a lot of people think IVF or, freezing your eggs and using them in the future. Oh, I'm going to have twins. Really, the risks of multiples were just when REIs were transferring multiple embryos. Because we can test the embryos now for aneuploidy, we really know how well an embryo is going to perform. And really, the standard of care now is just to transfer one embryo. So that multiples rate is almost, it's significantly lower than what it was before. There is some data that shows that the birth weight of babies born by IVF is slightly lower than spontaneous pregnancies. And there is some data too that shows that there's an increased risk of hypertension in women who conceive with IVF. ICSI is intracytoplasmic sperm injection. This is a method of fertilization that's very commonly used in the practice of fertility. It's essentially where you select one sperm and inject it directly into the egg. A lot of unexplained infertility we think is just due to the egg and the sperm not being able to fertilize properly. So ICSI lets us bypass that. So it's pretty standardly done in the field. And there is some data that shows that there's a very slight increased risk of birth defects with ICSI. It is still overall very, very, very small. So it's almost negligible, but just something to mention too. There's no increased risk of miscarriage with IVF. If there's actually a decreased risk of miscarriage when you're putting back a euploid embryo, the risk of miscarriage is lower than somebody who conceives spontaneously because we know it has a normal number of chromosomes. There's no increased risk of ectopic pregnancies, and there's no increased risk of breast cancer or ovarian cancer for women who undergo ovarian stimulation. The women have been doing this now, millions of women for 30 plus years. And so we have good data that shows that it is safe for women to do this. And then cost is, unfortunately, we're not at the point yet where insurance is covering all of this. Hopefully one day we will be. But generally, this can really vary clinic to clinic. Clinics can run deals on things and give discounts to certain people. So there's definitely a wide range of what it can cost, but I'd say generally egg freezing is somewhere between $6,000 to $12,000. Embryo freezing is probably more about 10 to 15. And that's because you're paying for all of the embryology lab fees up front. The fertilization, the growth of the embryos, the genetic testing. With egg freezing, you're obviously not paying that up front. You will have to pay it later if you go to use the eggs, but that's why embryo freezing is more expensive. That's all I had. So I will let Dr. Möller take over, and then I think we're going to save questions after her presentation.
Thank you so much, Dr. Schaub. That was incredibly informative.
All right, good evening. Thank you. Thank you for inviting me to be here with you tonight and do my presentation. So we're going to start by talking a little bit of the data that we know is out there regarding fertility and family planning during surgical training. What is important that we discuss fertility for residents and training? Well, fertility issues are important for all physicians hoping to start a family. This could be either male physicians for their partners, same-sex couples, as well as female physicians. Since our workforce has a good percentage of women on it, women suffer a higher risk of infertility, miscarriages, and pregnancy complications. And the other important thing is knowledge is power. The more that we know about the data, the more that we can make decisions to empower women regarding their fertility. We need to discuss this to take the stigma away and normalize the conversation. Infertility in female physicians has been suggested to be 1 in 4 females will suffer from infertility, well above the incidence of the standard US general population. Physician fertility and family planning are very rarely discussed as part of the formal education, either during medical school, residency, or during fellowship, or during even when you are in practice. There is a survey in 2016 of female physicians that showed that 25% of female surgeons struggle with infertility. 17% would have chosen a different field altogether if they knew they were going to be dealing with infertility. More than half of them would have attempted to conceive earlier, and 16% would have used cryopreservation to preserve the fertility. In another study, female academic professionals who postponed childbearing to allow for their professional advancement ended up involuntarily childless due to misconceptions about the risk of infertility. We will expect that doctors will know more about infertility, but in reality, we don't as much as we should. In an interesting survey that was done for OBGYN residents, it showed that the residents, 47% of them overestimated the age of marked decline in female fertility, and over 3/4 overestimated the success of IVF. When we look at childbearing decisions in residency, there was a multi-center survey of female residents across all fields, specialties, over 25 academic centers, and over 60% of the residents intentionally delayed childbirth because of residency. Those in specialties that were considered to be uncontrollable lifestyles, such as surgical specialties, were the most common, as well as being at a younger age, being in an academic center, and not being a parent yet. 38% of the residents who choose to postpone childbearing for residency initially were satisfied with this decision, but this declined as they age throughout residency. Another perception about pregnancies comes from this survey of the program's directors. This was done not long ago, in 2016. And in this national survey, the program director reported that 61% believe that becoming a parent will negatively affect a female trainee's work. In a survey by the Association of Women Surgeons, that has about 1,600 responders, it was found that there is still a stigma associated with pregnancy during training, but it has decreased over the past 30 years. However, it remained a challenge in about 69% of the recent graduates. Surgical residents and faculties of both sexes exerted a negative influence with regard to the perception of childbearing by surgery residents, but more men faculty and residents have this influence as compared to women. Attrition from and aversion to the field of surgery based on these perceived negative biases against pregnancy still persists during residency. Even though the residents were not openly discouraged from having children during residency, there were subtle but yet strong overtones that female residents should avoid pregnancy and childbearing until residency was over. In another study, when they look at the factors associated with the satisfaction for childbearing, more than half basically of the residents who were pregnant during residency, they reported being dissatisfied with residency, with their career, and this was significantly correlated with the fact that there is no official maternity leave policies, the perceived stigma, or the fact that they have to alter their fellowship training plans. In another survey of childbearing cardiothoracic surgeons, this was men and females survey here, we have that fewer females desire to have children when compared to men. And of those who did, 98% delayed pregnancy due to their career versus 50% of males. So females were more likely to assume that their career will be affected by choosing to have children as compared to men. And of those women that delayed childbirth, 24% require fertility treatment to conceive. Normally, this is about, based on the statistics, 9 to 12% in the general US population. So what are the consequences of delaying childbearing? Well, since we are delaying having children because we don't feel that the system support having pregnancies. So this would bring consequences such as the need later on in life to have assisted fertility, to the demands of the treatment protocols, IVF that fail, higher risk of miscarriages, higher risk pregnancies. And this will basically subsequently contribute to physical and emotional toll and burnout. And important to mention as well, the financial toxicity. This is a recent study that was published by Rangel and al. About the incidence of infertility and pregnancy complications in the US female surgeons. It was sent through different surgical societies, as well as through social media. And 850 surgeons responded, 692 women versus 158 men. And the partners of the no childbearing surgeons were used as the control group. There were multi-regression analysis, and the outcomes to be measured were the pregnancy complications, infertility, burnout, well-being, and career satisfaction. Childbearing surgeons were more likely, one of the results, and I was just going to mention some of them, were more likely to delay having children, having used assisted reproduction, being older at the time of the first pregnancy, have fewer children, and have fewer children than desired. Childbearing surgeons were more likely to have pregnancy complications such as preeclampsia, having to undergo a non-elective C-section, and having postpartum depression. Interesting on that data as well, before I pass, is that they found that working more than 12 hours, operating more than 12 hours a week for surgeons, female surgeons in their final trimester was increased the risk of pregnancy complications. Now, when we see the women that need assisted fertility, this is a very striking number on the survey. It's about 1,000 women, and they compare this survey with a survey by the Disease Control of the National Survey for Family Growth and the National Institute of Health data. And they found that women surgeons have 32% of these women reported fertility difficulties. 84% underwent fertility workup. If you think 84% of 1,000 women having to have, and these are women surgeons, right, having to have infertility workup, that's quite a number. And 3/4 needs to have assisted reproductive therapy to be able to get pregnant. Now, this highest rate of infertility were reported in ENT, general surgery, and orthopedics. So when we come and talk about the burnout, all this, the infertility, the high-risk pregnancies, the miscarriage, all these are going to contribute to the burnout of women, either as a cause, as a consequence, or both. And the evidence already suggests that female physicians are at higher risk of burnout compared to the male counterparts. And this is due to multiple factors, such including work-life integration and gender bias. And the physical and emotional consequences of infertility may have a profound impact in the overall physician well-being. In this study that we mentioned before by Rangel et al., I hope that I'm not butchering the last name, the pronunciation, it was found that in relation to infertility, women's surgeons that have been using assisted fertility, childbearing surgeons, or more than 60 hours and being an associate and full professor were associated with burnout. And when they look at well-being, having used IRT, childbearing surgeons and work more 16 hours was also having lower well-being scores. When we look at the financial toxicity, the economic burden of treatment is really high. A single cycle of IVF can go from $15,000, $20,000 and more. And sometimes it's more than one cycle that is needed. Multiple cycles can even add up to $100,000 in expensive. And the emotional and financial cost of this for the physician and trainings is important to understand by the trainees, because these are decisions that they need to make later on in life that will affect their finances. When surgeons report out-of-pocket expenses, you can see there is a large disparity, and that has to do with the legislation of different states mandating coverage for assisted fertility treatments. So we already know there is a problem with being able to have pregnancy to residency. We know that there is a problem that later on in life, these women surgeons that are delaying childbearing are going to suffer infertility or high-risk pregnancies or miscarriages. And that changes need to be made in the policies at the institutional level, at the leadership level. But while that happens, that's going to take time to make those changes. What can we do in the meantime to help the current residents, to empower the current residents to make decisions about their fertility? So that's when we come and discuss about like the importance of discussing the egg freezing or cryopreservation. Since 2012, this is no longer considered an elective procedure, but not considered an experimental procedure, but an elective procedure to as a means of preservation for fertility in women. This is an interesting map showing the few states in the country that will cover fertility preservation. There's only 17 states in the United States where this is mandatory. And out of those 17 states, 7 of them, which are the ones highlighted in yellow, are the ones that will cover egg freezing, but only when it's for medically induced infertility. So the rest of the people in the other states, if they want to have, if they need to have IVF, obviously this will not be covered. It will be up to their insurance or to their employer. And for egg freezing, kind of the same situation. So what are the challenges for surgery residents? Where there are very few resources available for them. Many programs do not even discuss fertility preservation with the residents, much less has program in place to assist with the fertility preservation. The prohibited costs, and residents often will have to hold these procedures by using their own time or receiving or having to take their own vacation or post-call days. And at this survey about the use of fertility preservation and plastic surgery trainees, only 5% of the trainees have used fertility preservation, and 19% have needed assisted reproductive technology. And one of the reasons that they had not been able, that they consider a barrier, had been the financial cost for the majority of them. So there is very little literature addressing fertility for surgical trainees. There will be a presentation we'll have at the Congress, coming at the Congress, when we are looking the coverage of fertility preservation and treatment on the U.S. surgical trainees, as well as what are the factors affecting family planning and them. So I invite you to attend that lecture so when we can present this data. But based on the current literature, the barriers to fertility preservation, as we know, is limited awareness, lack of insurance coverage, lack of access to fertility assessment and management, and institutional support for those undergoing treatment. So how to overcome these barriers? Awareness and education. We need to discuss the data and the statistic early on during medical school at the beginning of residency, so we can that way give the information to the residents and they make decisions such as opting for either fertility preservation or start their family planning. The important thing to discuss this topic in an open forum. This could be an isolated process for many, but if we normalize the conversation, we can provide support. And we also need to educate the residents about the occupational hazards that may put them at risk of infertility. The implementation, we can implement modules in the medical school or during the resident curriculum. We should provide the residents with resources where they can learn more about treatments, about options for them. And incorporating wellness in the annual checkups, such as incorporate the fertility checkup. This shouldn't be too expensive to send the labs, and that way they can be referred to a specialist if it's needed at the time. And have that access, provide that, those referrals, or at least a list of resources to the residents. The other important thing is not just to preach to the choir. We also need to educate the faculty. So that way they can become allies to the residents, so they can understand the treatment, how demanding this could be, so they can accommodate the residents to fulfill their duties during the rotations and being more understanding. And the other important thing is surgical societies and task forces that do what we are doing: webinars, publications, lectures, social media awareness. We are the Association of Women Surgeons. We will be coming out with a publication trying to address this issue. And recently, this was an Annals of Surgery. This is from the presidential address of Dr. Kim, and the work as well of Dr. Rahel about the importance of normalizing childbearing during residency. And the last but not least is the insurance coverage. We need to ease the financial burden, and we need to be more open, either at time of recruitment, disclose to the residents if there is what type of coverage they have for fertility or the lack thereof, and if there is no coverage, provide them with information of other resources. And if it's possible, subsidize the cost. We can have residents and fellow-run clinics when they can be staffed by reproductive endocrinologist faculty, grant application, and discounted services. And efforts should be made through the GME and the resident unions to make sure the insurance that are provided are the one that has the best benefits to cover those needs. And the other important factor is the psychological support, counseling that needs to be provided. This is a process that could be very emotional and isolated for some women, and also to be associated with a stigma. And we shouldn't underestimate the negative effects of stress on fertility treatment. Up to 67% of women report symptoms of depression when dealing with failed cycles, as well as anger, anxiety, and isolation. In resident support groups, when they can talk, when they can share information to each other and have guidance to undergo the process either of IVF or egg freezing. And the program support to allow for flexibility in the schedule, so they can accommodate, the residents can accommodate the visits to the doctor, the ultrasounds, instead of utilizing personal vacation or sick time. And the program director should strive for a supporting environment, so this process is not perceived as a burden. And the process should be treated with the same respect and compassion as anyone needing medical assistance. And to finalize the take-home points, the National Surgeons Workforce has now a larger number of women pursuing surgical careers over the last decade. And fertility shouldn't be a detrimental factor to engage women in pursuing surgical careers. Their biological clocks shouldn't be at odds with their career development. Management and prevention of female surgery fertility deserve more research to advocate for changes in institutional policies and supporting resources. So in summary, fertility preservation and assisted reproductive therapies are real challenges experienced by women in surgery. There are still multiple barriers that still exist, and lack of data, awareness, understanding, insurance coverage, and logistical support and institutional support are some of them. The physical and emotional burden tends to be handled as an isolated experience, and we need to stop doing that. We need to support these women, and we need to speak this topic openly. The time is now to discuss these issues, implement strategies, and the institutional policies to address fertility challenges experienced by residents in surgery. Thank you very much. Questions?
Thank you so much, Dr. Möller. That was a great talk, including a lot of data that really underscores the importance of why we're here tonight to discuss fertility specifically for surgical trainees. Again, I welcome anybody to submit questions to the chat box or raise your hand if you would like to ask a question. I can get things started with a question myself. And I know that we're kind of approaching 8:30, but I am willing to stay on the line for a few extra minutes, and perhaps Dr. Schaub and Dr. Möller will be willing as well, since we are running short on time if there are some questions. Okay, so we do have a question from the chat. So how do these numbers compare to other high-income countries?
Is that referring to infertility and pregnancy complications in surgeons specifically? Is that the numbers?
Yeah, more like the support and I guess the awareness of these problems, because I think the United States has an underlying issue in general. I missed the first half, so maybe you guys already talked about that, but we really don't have great maternal care here. anyways to begin with, compared to a lot of other high income countries. So from that basis, are female surgeons in other countries or other continents having these same trends with the later pregnancies, more difficulty securing support from the institution, more difficulty getting pregnant, things like that?
Yeah, that's a great question. I actually don't know. I've never seen data from other countries, so I really don't know. I don't know if Dr. Möller, if you know, if you've seen any data.
No, when I was looking at at all this data, unfortunately, number one in Latin America, at least, or in other countries, the workforce of female surgeons is even lower. We have here in the United States right now, the female surgeons make about 20% of all surgeons in the country. And Latin America and other countries, that's even smaller numbers. So there is not much data for women in surgery in those countries that I could find when I was doing the research.
Thank you.
All right, I have a question for you, actually. I know that you talked a little bit, Dr. Schaub, about the actual logistics of undergoing egg retrieval. But could you talk a little bit more about what you would advise someone who is in the middle of their surgery residency as far as how they could possibly incorporate this into their schedule, how much time they might need to take off of work, et cetera?
Yeah, that's a great question. So typically this process, it always starts basically with your period. If somebody is on birth control, that's fine. We could basically start with the birth control, but what we typically do is once your period starts, we start birth control pills for about 10 to 14 days, and we can play with that period of time and change it a little bit to fit somebody's schedule, to get them on an easier rotation, et cetera. We can do for a little bit longer or shorter period of time. And then when we stop the pills, you typically start the stimulation, the injections about 2 to 4 days later. Usually we have somebody come in for an ultrasound on that first day that you're going to start the gonadotropins, because we want to make sure everything looks good before we start the medications and start the whole process. So that's a transvaginal ultrasound and blood work. So that's typically going to take, maybe about 30 minutes to do in the morning. And it's pretty standard for clinics to do this all in the morning. And what time kind of varies. Like the clinic I'm at right now, we open at 6:30 for monitoring. So people can come in and, it's not really that helpful for surgery residents, but other people can come in and do monitoring before they go to work. And then some other clinics do open later. So during this period of time, I think you really would need to be on an easier rotation, and you would have to have some leeway with coming to work a little bit later, potentially, like just knowing what the hours are, because you do have to come in for monitoring. So we typically do that on the first day when you start the gonadotropins. Again, you're on those for about 10 to 12 days. So the first few days, we just kind of let you do the medications at home, because it's going to take some time for the follicles to grow. And then about 3 or 4 days in, we have you come in for another ultrasound and blood work. And then at that point, it's usually every other day. So usually about maybe 3 more ultrasounds before we can figure out when the trigger is going to be. So I would say you don't need to take off any time from work, but you would need to potentially be able to come to work later on those days where you're getting monitored. So it's probably about 4 or 5 days total. Then with the egg retrieval, there is obviously anesthesia involved, so you can't go to work that day. So you would have to take off that whole day from work. Most people do go back to work the next day after the egg retrieval, and they feel pretty good. So I think, pending that everything, goes okay, you'd be able to do that. So you'd need a little bit of flexibility in the mornings, probably about 4, maybe 5 mornings, and then 1 full day off for the egg retrieval.
Great, thank you.
Mm-hmm.
Okay, so we have another question. So looking back as a medical student or incoming intern, how would you recommend we begin planning for fertility preservation at this point versus maybe later on in the future?
Yeah, I think if you're thinking about it now, that's great. I think really just even thinking about it earlier is really important. If fertility preservation is available to you financially and time-wise, People always want to know, when should I freeze my eggs by? I would say ideally, to be honest, less than 33 is the best time to do it, before you turn 33. If you can do it at any point in your 30s, that's obviously better than doing it later. But if you were able to do it at some point during training, and I know, there's some programs in the country where it is covered for residents and employees of the hospital, not very many, unfortunately. But I would really say the earlier, the better.
And just to clarify, this is really kind of like an insurance policy that you're really kind of taking out for yourself, just so that you have a backup. If in the future you do experience infertility, then you have this resource that you can go to, correct?
Absolutely, yeah. I mean, if you never have to use them, I guess it was a waste of money, but if it gave you some peace of mind, I think that that's invaluable. So obviously, if patients can get pregnant on their own when they are ready, that's fantastic. And if you never have to use the eggs, we do tell a lot of women in their early mid-30s who are interested in egg freezing, hopefully this is for a second child.
I had a conversation this morning actually with one of our male residents who actually his wife is planning to do the egg freezing right now, because as residents, for them right now, it's very difficult to afford childcare and being able to sustain, have a child economically. So it makes sense, right? So when they finish residency and they're graduated, their economical situation will be different, but they will be older. So they are trying to be proactive now. And that's a way as well, to say, well, financially, I cannot support it at this moment, but I will be able to do it later. I think the other thing is, it's very important, I think, that early on, we can expect that all the program directors are going to be on the same page, that everybody is going to be so open-minded as we're trying to raise the awareness. But you can take charge, and you can go to your program directors and say, I want to know what that policy is. And you can ask those things when you're going to, should encourage the medical students. We need to start encouraging people to ask this question directly, not to be shy about it. And they can ask during recruitment, what is your policy, your health insurance cover for fertility treatment and egg preservation? They say, we don't cover it. What resources are there for the residents? And I think that we help programs to start realizing that there's a different generation now, and that there is awareness, and that we need to start at least providing the information to the residents. And the other thing is, if you are starting either as a new intern or in the middle of residency, when you see your rotation of your planning, try to bring that to the administration and talk to your other residents, talk about it, because you may be surprised that there's many other people probably going through the same ideas in their mind, and they just don't feel comfortable talking. But once that you find the right person, there will be others that may be part of that group. And if you come as a group and go to your administration and say, we want to pursue, we want to make some changes in our schedule and our rotations to facilitate this, it should be doable. I know it's going to take somebody some time to start looking at switching the stuff, and nobody may be happy doing that, but it's worth it. And it's important, because this time is crucial, because this is the time when you can get a good batch of eggs, but this is the time when you can get better resource, when you're still young, when these eggs will still be healthy by, you turn 40 or you turn 38, and you're doing this when you are much younger. It's the age of your egg, right? It's not your age where it's going to drive the success. So empower yourself with the knowledge, and also be upfront with these things. Don't be shy.
Yeah, I will say, when I went through one cycle of egg freezing when I was a clinical PGY2, and I was really nervous about scheduling it. And when I approached my program director just to let him know that I was planning on doing this, and he was incredibly supportive. I thought it was going to be a huge burden to my co-residents that I was on service with, because our clinic here didn't open until 7:30 in the morning. So knowing that, and it was at a different location than our main hospital. So I was planning, to do this over a week of vacation, which for me, it was worth it to use a week of vacation to to do this and go through with it, but I still needed to have some appointments during the week before my vacation where I had to, miss rounds or have someone cover for me for a couple of hours while I went to my appointment. And just had to be cognizant of when I needed to give myself the injections and work that in with my schedule. But, my program was very supportive of me doing it, and it was totally feasible to do while I was a busy clinical resident. But that being said, I did choose to do it over a week of vacation just to make it a little bit less logistically stressful for me, but totally feasible.
And honestly is, you remember you are doing this as a security blanket, right? But when you have to be in my situation, when you are trying to do IVF because you don't have the security blanket, and the IBS is the hope that you have to start a family, then you get a level of stress that is way higher. And there are plenty of studies that show that dealing with those stress hormones that affect you negatively to that. And it was very hard for me because my clinic was far away at the time. My institution did not cover IVF, our health plan, so everything has to be out of pocket. And the clinic that I was going to was far away, and I was like trying to get out of the OR, finish the case, get in the car, drive there, get the ultrasound. It was extremely stressful. And I think, obviously in retrospect, I wish I would have known everything I know now to make different decisions. And don't have to deal with those, with number one, with expenses, and number two, with the difficulties of trying to undergo my treatment. So if you can do it now, when you don't have to deal with that anxiety level that, sometimes you may not have a good cycle, and you may produce the quality of eggs that you're expecting to produce for fertilization because you're in an older age group. So younger patients don't have to deal with that level of anxiety when you are doing it as a backup.
All right. Are there any other questions from the audience? It looks like if you want to type them in, I think they would go to Brian Carpenter, and then he may be able to repost them in the chat. Or you can just speak up if you would like. Dr. Schaub, I have another question for you, actually. What kind of financial kind of planning options are there short of just paying out of pocket with cash? Are there like loans that people can take out or other things that are available?
Yes, there are. And unfortunately, a lot of people do that, but yes, you can take out loans in order to pay for it. A lot of clinics will set up payment plans too. That you can pay back over a period of time. So it's not just 100% cash up front. That obviously varies from clinic to clinic, and just kind of depends on, whatever their policy is. But yeah, there's definitely options.
Our residents recently one of our residents that was going through egg freezing was able to find this plan that is called, I believe, Win Fertility. And what they do is they give a discounted price, and they were able to negotiate with the health insurance to give them the discounted, like I think it's like 40% will be covered and the rest will be out of pocket. But there are some programs like that. So I think probably will be good maybe if we can collect some of those programs information, and maybe at the bottom of this lecture put those links for people that will be interested in pursuing those venues.
Yeah. And I would say too, to anyone interested, definitely, they might not be able to offer it, but definitely ask for a professional discount. I rotate through a couple different clinics, and sometimes with the bigger university clinics, that's difficult to do because you have, the whole university, but other clinics will give professional discounts for physicians.
There is a question from the chats. Do you know how many programs actually have coverage for egg freezing or IVF?
Oh, I don't. I wish I did. That would be, I wonder, I would love to know that data, but I know, definitely ask on your interviews. I guess
Yeah.
if you're interested in it, but I don't know exactly. I just have heard from friends in residency who have had it paid for by their institution.
Yeah, well, you know, the thing is, most of those the states that I show you in the lecture, those 17 states, they definitely will cover your IVF, and they are actually many of those universities. When I spoke with some of the residents, is covering the egg freezing completely, especially in Massachusetts. I understand. California, it's kind of like to a certain extent, but the I think the important thing as well is the fact that, you know, we need to be more transparent on that. When we did some of the data that we have on that we wanted to know what programs, so many of the residents didn't even know they had coverage. So it's not completely out there up front. So I think we need to advocate for that to change as well.
Definitely, I agree.
I will just say to you, when I was going through kind of researching where to do this, there are private practices that you can go through. Like one of them that comes to mind is Shady Grove Fertility. That's a pretty big practice, and they do have some plans out there where you know, they'll guarantee you 20 eggs with however many cycles it takes. Of course, they have some restrictions on who qualifies for that and how many cycles would be your cap. But there are some plans out there where you would pay a flat fee with the hope of, say, getting 20 eggs. The way I did it, I just paid for one cycle, and you know, not really knowing how many I would get, but just hoping for the best. So I would encourage you to do your research and see what your options are. Of course, knowing that the convenience that you're paying for, me being in Gainesville, there aren't really many clinics that are close by. So that kind of limited my options a little bit, but something to keep in mind.
That's very good.
All right, looks like
I'm just seeing the question now. I'm sorry, I saw that you were asking about low-income countries. Now I'm seeing that the question was about other high-income countries. And the answer is, I don't know. There will be an interesting thing to compare that. But if you think of how we handle pregnancy here, it makes a big difference compared to Europe, when the residencies, the residents, here we take for maternity leave 4 weeks, 8 weeks at most, right? In some other places. In Europe, you can take 6 months to a year being a surgery resident, and half of that could be paid out of, you know, you are being on maternity leave and it's paid. I know for sure in Ireland you get 6 months, and you can go and take additional time when you go part-time, and there is a grant or some funding by the government that will pay for the part-time. And if you work more of the part-time hours, the institution should have to make up for the difference. And what they do is, people don't graduate here. We have residents to graduate a specific weeks of training, right? There, okay, you go on your year maternity leave or your 6 months, and then you go back to your rotations. Rotations accommodate people graduate at a different times in the year. And I think that's something that we can learn from them, those strategies. So people had children. It's not a burden from residency to have children, because they, number one, they have a longer time to be at home with their kids. And number two, the system, the country system for childcare has a more supportive environment that we have here in the United States when childcare is an issue as well. So having those benefits, probably people is not as pressed when it comes to delaying pregnancy as much, because the system support it better.
Yeah, thank you. I was in particular even referring to Finland because they have really crazy maternity leave there, and it's maternity paternity. So the dads and the partners can take the time that they need as well. And then they pay you per child. And then, like you said, they have government nannies, and they have the childcare there is very, really robust. So I think it's a reflection, but if anyone can spearhead this, I think it's the female surgeons of America. Get America back on track.
You're absolutely right. And the thing is, residency takes a little longer in those countries, surgery residency. But I will tell you, I will not mind that my residency will be a little longer if I know that during my residency, I can be a year off with my child, make it grow and continue my career. So I think it's just the different way we see the world and what we expect of ourselves and society expect from us.
Yeah, exactly. Thank you so much.
Are you all aware of any legislation or advocacy that we could participate in to, try to expand the support that residents may receive?
I think there is a strong, the academic, if you see the Association of Academic Surgeons has made a big statement on it. I think there are multiple task forces right now happening across different organizations and societies on trying to make changes to this. I recall from a long time ago, even when I was a junior faculty as well, that we were discussing about the maternity leave for fellows, because the fellowship is such a short time that was very difficult for the fellows to take. The ones that had C-section, they couldn't take more than 4 weeks. And they were talking about changing things from, a week space to a competency week. So if you were able to accomplish doing, let's say, a skin aspirin mastectomy, it took you 2 weeks to learn to do it versus a month. Well, you don't need to stay a month to do that, right? It's just to give you a random example. So we should change the way that we expect people to accomplish, to be proficient. It doesn't, there are so many creative ways to go around that we can send people in research when they are with their children, then trying to accommodate those things during residency as well. So I think it's gonna take time, but I'm very hopeful that we are making strides in the right direction, that we are having more people to support, not only from the female side, but also from the male side, understanding how this affects all of us. And I believe it's going to take time, but I think things will change little by little.
Thank you, Dr. Möller. That kind of answers the next question, but maybe you have some more to add. If there's anything else that we can do to bring up to ACGME to try to advocate for parental leave policies. If there's something on an individual level, or if you would suggest kind of going through larger organizations, how can we approach ACGME about this?
I think that is multiple ways to do it. Obviously, one of the big blocks has been basically how the ACGME makes residency being constrained on that time of training, right? But I think at your local level, continue participating in advocacy committees such as RAS, the Young Fellows Association, the College Association of Women Surgeons, Academic Surgeons, being part of those committees, bring your voice to those things. There will be right now with the college is very open to this. There is right now a big session. It has to do with maternity and family planning and fertility. And this is something that has been for years that were being submitted to be accepted by the college. And now this year, there is a huge session with a lot of topics. And I will invite you to be in that session, listen to the people, since who are the individuals that are interested in making change, and start being united on that. I think there are a lot that can be done, and every person is important in this endeavor. And the more that we continue, social media is a great tool, and I think is another one that we need to utilize to bring awareness, to get the key players to respond to this. So times are changing, and I have a lot of hope in the younger people to help us with these changes.
That's a great point. I think social media, if we can tag these organizations like ACGME or women surgeons and really get more traction, it's not something that they're going to be able to ignore. So
yeah, and the thing is, this new generation of surgeons, they see life different, and we still want to attract into surgery the brightest women, that we want to bring, that our field, that we don't deter these brilliant medical students to go away because of how they perceive surgery to be not family friendly, right? So I think that it is very, very important that we start making that very clear to the people up top, but also come with solutions. Because we know there is a problem and we can say that it's a problem, but what will be the solution? Well, for this generation, these things will work. And like I say, let's go on competency base. Let's extend the period if you need to take the time off, but let's take longer to graduate, and that's okay. So we need to find solutions, and I think we need to look at models from other countries that are doing it better than we do. And we may not be able to incorporate everything because we are a different society, but at least we use some of their strategies to help us make some changes.
Thank you. All right. Are there any other questions that folks may have? I don't see anything else popping up in the chat. So guess we can go ahead and wrap up here. Again, I would like to thank Dr. Schaub and Dr. Möller for taking the time to meet with us tonight, share your insights, your knowledge, your experience with us. It was incredibly informative, and I think these are just the first steps that we have in taking to destigmatize this and to really make some positive change for everyone. So thank you very much.
And thank you, you guys, for putting this together and giving us the opportunity to talk here.
Yeah, thank you guys.